Just to elaborate a little bit more on these high-risk situations, to give you some examples, imagine the person who has vascular surgery, and so they already have poor perfusion that's already compromised, likely in several extremities of their body, much less wherever the vascular surgery is being done. So lying in a awkward position for a long period of time, or with a extremity strapped down in a certain way, could have potential for significantly compromising their circulation in that area. And so those are things you want to key into and look for. Patients that have cancers or metastatic cancer that's went to the bones, or osteoporosis, tend to have what they call demineralizing bone conditions, and so their bones are very, very porous, very fragile, and they can actually have a compression fracture based on the length of time in an OR in a certain position, and you're not able to tell the person, this is hurting me, or this broke, or whatever, because you're not alert enough to know that. So not only do the OR staff themselves have to really be cautious about how they do some of this, and then to prevent, sustained pressure on the body from a pressure ulcer standpoint, but they, PACU nurses or in the recovery room, as well as you receiving the patient back to the floor, need to, when the patient's more and more alert, may begin to be able to complain of some of these things, and you want to know that it could have come from some of these type of issues. These are just a list of all the positioning devices that you might see used, and all that may be depending on the case, the position, what area of the body they need to hold down or place in a certain way. So we're going to talk a little bit about post-operative care. Your Chapter 17 mostly deals with the post-anesthesia care unit as the immediate post-operative care, but quite a bit of this also applies to post-operative care, that you will continue on the floor after receiving a patient from the PACU as well. So, they may not be as closely monitored, but you will still have post-operative vital signs that are fairly frequent for a certain period of time as you get the patient to you. But to know what the PACU has done and how it works there is real helpful for you, since that's where you're getting the patient from. There are 3 phases of post-anesthesia care, and this is just kind of a distinction that lets you know certain values about the patient. How alert and oriented are they? Are they breathing on their own? Is their cardiovascular status stable? Have they begun to recognize their surroundings and wake up? And so they have a set scoring system that they use in the PACU unit that lets them know when somebody is kind of meets the criteria for phase 2, and when they might be discharged, and those are based on what the anesthesiologist determines, because you remember I said earlier that anesthesia provides care in the OR, but they also kind of follow through and are the care provider for the patient in the PACU as well. And then, some patients may be discharged directly from the PACU if they're in an ambulatory care center, so they will likely have to achieve phase 3 because someone's going to take them home. Like I said, post-anesthesia care can be provided in many different settings. It can be an inpatient PACU. It can be they go directly from OR to the ICU. They can be in an outpatient center and go to an outpatient PACU. And then sometimes patients are going to have, some of these minor procedures where they have conscious sedation in what they call a procedure area of the hospital. And irregardless of where they have received anesthesia, they all have to have the exact same monitoring irregardless of the setting. So if they've had a particular type of anesthesia, they still need to be monitored for moving through those phases, even though that's not the typical thing you might always think you would do in an ICU. You may find in smaller hospitals sometimes they do that. This is just kind of the general things that a post-operative nurse is looking for. You're going to be assessing and monitoring the patient's response to the surgery and to the anesthesia. You're going to do timely interventions to resolve any problems that occur. You're going to evaluate the interventions that you do and then look for effects or side effects of medications, continually reassess the patient's condition, and then you're going to be constantly evaluating, based on that criteria, when have they achieved the discharge criteria so that they can move either to go home or can move to go to the floor. These are what the assessments entail: respiratory status, whether the patient is using accessory muscles to breathe and struggling, or are they, their muscles have been paralyzed because of the anesthesia, and so, they're not using them enough to really raise the diaphragm, and then they have the potential to become hypoxic. Vital signs, pain level, neurological function. Of course, we're hoping that they wake up, and when they wake up that they are, know where they are and know their name and are alert and oriented. Again, with vascular, we're looking at pulses all the way around, looking at skin temperature and color. If we've actually had vascular surgery on one extremity or the other, then we're comparing right and left and making sure that there is a consistent no change, as much or little change between the two, and monitoring that. We're looking at conditions of dressings in the visible incisions, if we have the ability to see that, watching to see if there's any drainage from drains, making sure that their IV catheter is patent and it's staying in place, because that's something that we really need as a rescue should they have complications. We're watching the urinary function, their GI function, and their overall fluid status in terms of how much fluid have they received in the OR, how much fluids are we giving them, and then how much urinary output are they having by comparison. When the OR staff moves the patient from the OR to the PACU, this is a list of all the typical handoff required things that should be covered. Of course, patient identification using two identifiers, the type of surgery that was performed. They give names and contact information in case they need to call them back about a complication or a problem, how much fluid they gave them in there in the OR, and then any estimated blood loss. Those are key things you would want to know. Sometimes patients get so much fluid in the OR itself that you may see respiratory complications from that because they're short of breath or having congestion in their lungs. So anytime somebody reports that there was a lot of boluses given or different things, you're going to watch for that. They're going to look at and see that all the lines and drains are intact. See how much is draining from some of the drains and what the color and consistency of that is. And they're going to want to report off important home medications that the patient's been on, because some of that could impact their care post-operatively. And then they list out any medications that have been administered or any that are left to be administered. Also, any actual or potential clinical issues that may have occurred in the OR. There could be some other non-clinical information like, family contact information, other things that are just important that are passed on from unit to unit, special wishes maybe of the patient. And then overall the plan of care and how they did during the case. Any diagnostic tests that have been done and those values, or any that are planned and need to be drawn during the PACU stay or later in the day. In terms of pain management, we've talked about that already a little bit in fundamentals. There are very specifics that you need to know: the location, the intensity. You need to be monitoring things like what triggers pain. And of course, in this setting, we know that the surgery itself is going to trigger pain. If the patient has expressed any fears about pain medication, they may be less likely to take enough. If they've had chronic or past use of opioid medications, they may have a tolerance and need extra medication to get the same effect. And then any methods that the patient uses to reduce anxiety already or improve comfort would be helpful to know. And and the other thing is having the family at bedside helpful, or does the patient prefer to be alone in terms of being quiet and calm and maybe rest? Sometimes families come in a big army of people, and then the patient can't rest and can't sleep, and then they're constantly telling you they need more pain medicine. And in reality, if they just didn't have all that noise and interruption, they might really rest in the PACU or on the immediate post-op unit. These are some of the other goals. You want to make sure that multimodal initially works really good immediately post-op, meaning you might give IV medications in PACU. Once you move to the floor and get new orders and the person has a diet order, they might have more than one IV med, or they may have an IV med and a more long-acting PO med, or they might be on a PCA and then something else later in their stay as they wean off of that. Providing patient education about preoperative pain management, as well as what they anticipate happening, is always good in advance, and having a kind of a plan for pain management that they're already aware of is good. PCA teaching for the patient and the family, if that applies, is required, because families under no circumstance can push the button for a PCA. It must be when the patient is awake enough to do that for themselves. Family visitation has been shown to have great benefits, decrease in anxiety, improve satisfaction, and makes the family feel more supported. But it's important before a visit, the nurse needs to make sure that the patient is really awake and that pain is well controlled and that they really are wanting to have a visit. You may have to set expectations regarding how long a visit should be, and particularly when you're talking about the PACU, you may just let them in for a short period of time and then have them back out. But explaining all that, in terms of the environment and what all's there and all the equipment, may help decrease some of the family's anxiety. These are the typical interventions and actions that you see in the PACU. When you get the patient back immediately, you're going to put them on a monitor, start an admission assessment, get all your data, do continuous monitoring of the patient throughout their whole stay, medicate them for pain and nausea. Again, do teaching. You may, if your family doesn't visit, you may make a rule to kind of contact them every hour to kind of let them know how things are going and clearly notify them when the patient is ready for transfer out and or discharge. If they are going to be discharged to home, then you want the family really involved with discharge instructions, because the patient still may have some after effect of some of the sedatives, and you want to make sure that somebody very clear-headed is able to teach back that discharge information so that things are going to go well when they get home. These are some potential complications. We've talked a little bit about patients developing atelectasis after surgery, but the biggest potential complications in the PACU are respiratory depression from anesthesia, which means you're going to have a bag mask available to help breathe for them. You may need, they're going to clearly be on oxygen in there, but you may need to monitor that oxygenation level. You're going to be constantly monitoring that. You're giving pain medications also during that phase, and so that may add to some of the respiratory depression complications. And of course, there can be bleeding risk from surgery itself. And then other serious conditions that you're watching for. If somebody's been under a lot of stress, they could get hypervolemic.